Today, we're going to talk about this very important clinical condition, specifically in the neurology departments. We come across these patients who would be unresponsive to any kind of stimuli, may it be light, touch, pressure, pain. All of these stimuli cannot really produce arousal in these patients. We can also say that these are the unconscious individuals for a prolonged period of time. How can we scientifically prove that this particular patient is basically suffering from coma, or either this patient is comatose? How would we really define this condition? So there are some criteria that we're going to see and look for in these particular patients. First of all, obviously, the lack of arousal in these patients is making us suspicious. It's not just a common lethargy, or it's not just a common unconsciousness that the patient is suffering from, but it is a comatose condition that the patient is having. Then again, the abnormal sleep-wake patterns in these individuals are also highlighting this particular condition in them. So they would be lacking these normal sleep-wake patterns in their, if we perform their EEGs, and that is going to be a diagnostic criteria. On the GCS, when we have these patients, one should know what are we going to look for? How are we going to basically just diagnose whether this is there's a lack of consciousness, there is a lack of arousal, or there is some other problems, as we're going to just go through the differentials as well that you're going to keep in mind when you have these patients. Working on the ERs, you would be getting these patients, and you should know how to get to their etiological factors. What are the factors that are triggering these comatose conditions is very important. So you'd be looking for these factors, and again, distinguishing them from the other conditions which can mimic the comatose conditions in a patient. So this is what we're going to look for, and we're going to list down the causative factors for the mimicking conditions, as well as the conditions or the etiological factors, the underlying pathologies that can contribute towards the development of this comatose conditions in the patient. So first of all, I would like to highlight these factors that when we have these comatose patients, there are a lot of terminologies that are basically obsolete nowadays, and we're not using them. For instance, the terms such as lethargy or semi-coma, obtentation, these are some of the terminologies that we should avoid using for these patients of coma. Instead, we should look for the causative factor, the exact etiological factor, or even we should even look for the list of the differentials at our hand. So what are the conditions that can mimic a comatose condition in a patient? For instance, we have abulia. It's one of the terminologies that is used for patients that cannot really perform the motor reflexes. So this is one of the conditions that can mimic a comatose patient. The underlying pathologies are more of psychological in their aspect rather than any other causative factors, as we'd be just focusing on the fact that there are a lot of factors, for instance, infectious states, raised intracranial pressures due to any kind of mass that is present in the central nervous system. And that in turn can produce a lot of conditions. For instance, herniation is one of the phenomena which we usually come across, and that is even pressurizing the different aspects, as we'd be looking for the specific anatomical features that are basically contributing towards the development of this state of unconsciousness in the patients. So we'd be focusing that infections, masses, it can be metabolic conditions, miscellaneous metabolic conditions, multiple organs can even contribute towards the development of the metabolic abnormalities, metabolic disturbances in the body, and eventually result in the lack of consciousness on that particular individual. So on the list of the differentials, coming back to that particular differentials that we were discussing, we have abulia first of all, and then we have another, basically it's also one of the stages of the comatose patients. It's regarded as the vegetative state in the individuals. So the vegetative state is sometimes also termed as the permanent vegetative condition of the individual. Why is that so? Because the prognostic factors for the vegetative state are really poor. So usually the patients do not come out of it. The causative factors for the prediction of this vegetative state are usually trauma, and it can be even the cardiac arrest that can cardiac dysfunctionality in the individual that can basically result in the decrease in the cerebral blood flow and eventually resulting in the vegetative state of the individual. So vegetative state or the permanent vegetative state can be one of the conditions, and it's also described as one of the stages of coma. We do not have exactly the typical stages seen as we see in the other diseases, but we have this vegetative state, which is a more severe form of a comatose patient. And then we have another stage, which is basically the minimally conscious patient. MCS is an abbreviation which is used for the patients who are a bit higher on the GCS, that is the Glasgow Coma scaling, when you evaluate these patients in your ERs, and you can categorize these patients to be on the MCS. The prognostic factors for the patients who are in the MCS, they are much better than that of the patients who are in the permanent vegetative state or the permanent vegetative condition of the body. So differentiating these two categories is again very important, because if we usually manage the patients of minimally conscious state or MCS with thiamine, naloxone, and provide them with glucose drips, they usually respond very well to this treatment. And this is what our aim as a physician is, to basically produce arousal in these patients as early as possible by providing vigorous treatment to them. So this is the approach that you should have towards these particular comatose patients. Moving on in the list, we have catatonia. Now, catatonia is basically one of the psychological conditions that can arise in the individuals. It's more of a psychological state, a psychopathic abnormality, and rather we also devise these patients when we look at the history. They're sometimes suffering from milder forms of schizophrenia. So they would be usually presenting to you with these severe forms of areflexia and motor abnormalities, lack of performing voluntary movements on their own. And all of these are basically, again, one of the characterizations in which we can define that these patients have catatonia. Taking the history is again very important when you have these patients. So when you take the detailed history, either the medical history or the surgical interventions that the patient has undergone, any diagnosed conditions that the patient has already been diagnosed with, or any other drugs that he has been taking, or any other prescriptions that he has been following on, is very critical over here. So you'd be looking for all of these when you're taking the detailed account. Obviously not from the patient. It's going to be a corroborative form of history from the relatives or whosoever brought the patient to the emergency department. So this is going to basically make the diagnosis more easier for you and make the working for the underlying etiological or the underlying pathological features more easier for you when you have these trigger points in your history taking. You document the history in detail over here and you look for these particular features. Either the patient can suffer from catatonia, either he had suffered from any recent traumatic history, either he had any other CVAs, cerebrovascular accidents that he had undergone. So this is going to highlight a lot of factors, even taking the history, for instance, if he's already been a diabetic patient or hypertensive, that is going to even highlight the etiological mechanisms or the pathological mechanisms for these patients. So looking for these history points, again, family history is very important. You're going to look for any diseases that run into the families, and you're going to even highlight the particular factors that can contribute to the development of this vegetative condition, this unresponsive state in the individual. Then it is again very important to differentiate patients of coma from patients that are also termed as the locked-in syndrome. This is a terminology used for a lot of patients. Now, what happens over here in the locked-in syndrome is that only the descending tracts are severed due to any kind of traumatic condition, and that is resulting in this locked-in syndrome. The difference between a comatose patient and a patient who is suffering from this locked-in syndrome is that basically they can perceive these stimuli. They can hear your voices and they can even respond to your commands by the eye movements. So you usually ask the patient to move the eye, and these eye movements are indicative of the fact that they are suffering from this locked-in syndrome, and they can really listen to your commands. And the only pathology that they are going to suffer from is that they are going to lack the voluntary movements in their limbs or perform any voluntary actions at all, except for the eye movements that are usually present in these particular patients. So distinguishing these two factors is again very important. The prognosis is entirely different for both of these states, and even the treatment and the management plans are entirely different for both of these patients. Then moving down the list, we have the Guillain-Barré syndrome. Now, the Guillain-Barré syndrome, it's basically an autoimmune disorder. The underlying basic pathology behind this Guillain-Barré syndrome is the autoimmunity, and that is responding in the decreased muscle reflexes and in the lack of the voluntary movements, lack of ability to perform the voluntary movements in the individual. Again, it is going to depend upon the severity of the disease, and that is going to result in the particular kind of vegetative state that usually develops in these patients of Guillain-Barré syndrome, either over a passage of time, and in a lot of patients is usually an acute attack of Guillain-Barré syndrome, and they usually suffer from this condition, but the prognosis is very good for these patients of Guillain-Barré syndrome. When they're treated with the particular management guidelines, they usually respond very well to these treatment guidelines, and they usually come back to their normal performing the different daily activities, usually without any permanent losses in their voluntary movements. So knowing this list of differentials is going to help you a lot in your rotations and basically help you identify the different underlying pathological factors for the basic pathology of unresponsiveness or the unconsciousness that you're going to deal in with, and obviously help you decide what are the different treatment guidelines that you're going to follow for a particular patient.